So for those that I've not met before, my name's Claire Howard. I'm the clinical lead working with Wessex Health Innovation Network, and I'm also the national lead for the polypharmacy programme. So I'm going to talk to you today a little bit about what the data tells us about polypharmacy, about the things we can do to support you. So that's both GPs, pharmacists, pharmacy technicians, and other members of the practice team to make sure you're doing SMRs in the right way for the right patients, with some of the right materials to help you give you a fighting chance of doing successful SMRs. So before I do that, the pharmacists on the call, I'm sure will have seen me present this slide. Everywhere I go, I take this slide because it's really important, and people haven't got a true understanding sometimes of the scale of problematic polypharmacy. So every month I look at the data, and from July's prescribing data, there were over 1.3 million people who received 10 or more medicines, and that's not everything. That's BNF chapters 1 to 4 and 6 to 10. So the medicines they take for long-term conditions. Over 500,000 of those people were aged 75 and over. That's near over 10% of the population of over 75-year-olds. And the reason being over 75 and on 10 or more medicines is important that we pay attention to is because the literature's starting to show us that that is the tipping point for patients to experience harm from the number of medicines they're taking. In some more deprived areas, that harm can happen earlier, but at a big population level, that's where we need to be paying some attention. And I'll show you in a minute the slide, the study that shows us what that's doing in terms of patients going into hospital. But much of the harm from problematic polypharmacy is preventable if we had the structures in place kind of upstream to review those patients. And interesting that many of you in the kind of barriers and challenges talked about time and being able to find the right patients, etc. It's important because it has some big impacts. I've talked to you a little bit about the impact on a kind of patient level, but at global level in terms of the NHS, we dispense over 1 billion items every year in England. The drugs budget is the second biggest NHS budget after pay of NHS staff. So it's heading towards 20 billion. If we didn't get some of the rebates that we get, it would be almost at that now, and it's growing. And as I said a moment ago, 16.5% of unplanned hospital admissions are due to adverse drug reactions, with polypharmacy being a major driver. And when we extrapolate that study that was done in the Northwest, the costs to the NHS are about 2.21 billion of those patients being in hospital for things that perhaps we could have done something about. There are studies that show that potentially inappropriate medicines in older people could be as high as 50% of prescribing, which is enormous when you think of the effort that goes into that and then the harm that we could be doing. And it's important that we start to address this now, because we've got, some of you, particularly those of you on the island, but in other parts of Hampshire and Isle of Wight, will know that a huge chunk of your practice population are already over 75. But at national level, 13% of the whole population will be over 75 by 2043. So it's an enormous challenge now, but it's only heading in one direction. And when we talk to clinicians, and I spend an awful lot of my time every week with GPs and pharmacists trying to do this better, confidence comes out as a really important theme, that in order to stop medicine safely, people sometimes don't feel they've got the confidence to do that. The other thing we know from the evidence base from GPs like Julian Treadwell, who's done a lot of research in this area, is that as clinicians, we overestimate the benefits of medicines and we underestimate the risks. And that's particularly acute in older people. So studies are often done in young, fit men, and then we want to apply the benefits of an anticoagulant in AF to someone who's now 82, weighs 6 stone and has challenges with their kidneys. So we're doing that constantly. And I guess if there's any one message around older people, it's that we've got to really think about prescribing in frailty needs a completely different mindset to how we would prescribe in sort of people in their 40s, where we're doing preventative medicine. So in terms of the prescribing picture, before the pandemic, we were just about keeping a lid on it. It was growing in terms of the number of people over 75 on 10 or more medicines. But since the pandemic, when all of the prescribing data became incredibly volatile, almost every measure you look at kind of went like that in April 2020. We've now got more people over 75 on 10 or more medicines, and it's heading upwards all of the time. you will all have a picture like this of patients that have either died or come in with all of their medicines and said, I don't take any of these. And it's heartbreaking on a number of levels. You know, I've talked about safety, but if you think of the energy and effort that went in from a very pressurized workforce in general practice and community pharmacy, checking that these medicines are right, dispensing them correctly, getting them to the patient getting them home, and then they just end up in a bag somewhere waiting to be incinerated. We're also starting to understand about the sort of global challenges of medicines as we take more and more of them, and the kind of marine pollution. So there's the net zero challenge in terms of carbon footprint, but we also understand the pollution in our marine systems from medicines either being thrown away or excreted are hugely challenging and are having an impact on marine life. So every medicine that was not needed in the first place has this kind of catastrophic knock on for almost every one of us linked in that chain. So think for yourselves for a moment, what do you think is the number one drug or class of drug that causes hospital admissions in this country? So just maybe think to yourselves, and I can't see the chat just now, but if you can maybe put in the chat, those of you that are feeling confident to know what that medicine is. So I'll give you a moment for that. And Kerry, I don't know if you can read out what if people are brave enough to put a drug class in the chat, and then I'll...
Yeah, so far we've got NSAIDs, DOACs, diuretics, antihypertensives, and opioids are our top ones.
Well, you're a much better informed. I was on a frailty course this week, and it was with all sorts of people who work in frailty, and I was really actually quite shocked at some of the drugs that people missed in terms of harm or put in terms of harm. So this is a really well-informed audience. So in terms of adverse drug reactions, you were on the money, quite a few of you. So the top cause is diuretics. Steroids are in there. That's the 30-day pneumonia risk with inhaled corticosteroids. When this work was done 20 years ago, non-steroidals were in that top list. In terms of deaths, GI bleeds are still, they cause over half of deaths linked to adverse drug reactions. But in terms of hospitalisation, interestingly, non-steroidals has dipped out of the top 10, but PPIs have come in. Chemotherapy's in there, antiplatelets, ACE inhibitors and opioids. So with the exception of chemotherapy, the rest of those medicines are medicines that we prescribe in primary care very, very routinely in very large numbers. And that's the paper that shows that 16.5% of unplanned hospital admissions were due to adverse drug reactions. About 20 years ago, when this same team did the same piece of work in a large number of hospitals, it was believed to be about 6.5%. So you rightly highlighted in your word cloud that this is kind of complicated. There are a number of factors that cause polypharmacy, and the National Overprescribing Review highlighted, good for you, good for us, good for everybody, some of the reasons why we have this challenge that we do have. And every time I teach on our Action Learning Set course, I always say, you know, nobody wakes up in the morning to be a poor prescriber. This is a system issue that we're all part of, and it will need a system response in order to address. I'm going to come back at the end to repeat prescribing. But we've been working for about 6 or 7 years now in Wessex with GPs, pharmacists from across Hampshire and Isle of Wight and Dorset. And we've now got a national polypharmacy programme which has 3 key components. First of all, you have to use data to select patients for structured medication reviews. There are far too many people out there on multiple medicines for you to just randomly see whoever knocks on the door or rings up. You've got to have data that shows you which of your patients are most at risk from harm. So we have the polypharmacy comparators, and we use that to help practices prioritise who needs a structured medication review. A number of you talked about confidence and issues around stopping medicines, and our pillar 2 is all about upskilling GPs and pharmacists and other prescribers to feel confident in a structured medication review scenario, because some of these issues are quite complex. How do you decide when the risk of an anticoagulant outweighs any benefits or is a problem with someone who's falling regularly? This stuff isn't always easy. So our polypharmacy action learning sets help grow your confidence. It's an evidence-based educational intervention. And then pillar 3 is all about public behaviour change. Patients don't really know what an SMR is, so how do we ensure they know what it is, they feel engaged to come to it and not turn up for their appointment, and when they come, they know what questions to ask you so that it's a good conversation about their medicines. So that's the work that we've been doing, and in our action learning sets, we do an exercise not dissimilar to the one you've just done now, and we say, what are the barriers? And we ask people to talk about the barriers in the system, but also their personal barriers. And if we spent a bit longer on that today, you would come out with all of those issues that we've uncovered over the last 5 or 6 years. And, you know, QOF and things driving us to prescribe are the environmental barriers, and the personal barriers tend to be time, confidence, pressure to prescribe, worried what the patient will think if you stop these medicines. And we cover all of that in the training. And those barriers and facilitators to unlock this were also highlighted in a paper by a researcher called Daniel Okiowu, who has done a huge amount of research uncovering why it is that we've got all of these challenges to stopping medicines safely. So it is a complex issue, but the bedrock of the solution to it is structured medication reviews. And I've been in the NHS a very long time, and I think people have sometimes forgotten that the evidence base upon which pharmacists were brought into general practice, I worked in general practice 20 plus years ago where there was no national scheme for bringing pharmacists in, but we could see the contribution we could make if we were part of that team working with GPs. But more recently, the evidence base upon which that business case was granted, upon which the R's roles were secured, was structured medication reviews. So when pharmacists do medication reviews with the right patients carefully selected, we know they have an impact on this problematic polypharmacy. So SMRs are a nice defined intervention. They're the best tested intervention to reduce problematic polypharmacy. And I'll show you in a second, they have a very strong economic case around them, not only around the number of medicines that are stopped, if you like, or the drugs bill side of that, but also in terms of patients who get them tend to use less NHS resource after that. So we've got a growing evidence base as well that supports that. And there's a study from Oxford called the OSCAR study about to publish soon. But patients don't always know what they are, and they're not universally applied. So when I look at the data, as I do every month, that shows me how many SMRs are being done across the patch, it's enormously variable. So there are PCNs who do lots of SMRs and have systems in place, and you're going to hear from Lawrence Brad and other GPs who've set that up. But we've also got practices. I was working with a practice a couple of weeks ago who said to me, I didn't know there was a code for an SMR, and we don't routinely call patients in. So we've got a huge amount of work, because if we're going to do anything to support those older patients, we've got to be doing SMRs in far, far more than 1.1% of all the appointments that we see. So you'll see there from Hampshire and Isle of Wight's perspective, we've got work to do, but you're not alone. You know, there's other PCNs and ICBs in exactly the same situation. Dorset probably are a little bit further ahead in terms of this journey. They've been measuring at practice level who's being seen, how many SMRs, and what the impact of that is. And I'll show you some of that data in a second. The network contract DARES has always contained information about what you're expected to do. So pharmacists are expected to be seeing patients. The wording changes every couple of years, but it's largely along the lines of proactively see. So seek out patients at risk from harm, those with complex polypharmacy, traditionally those over 75 and 10 or more medicines, and particularly those in care homes or with multimorbidity. So it is in the PCN DARES. But I think it is also important that when we're looking at polypharmacy, people often say to me, oh, well, NICE guidance says we have to prescribe, or QOF says we have to prescribe. I can understand why we've come to that conclusion. There is a lot of pressure to prescribe. But actually, if you read every single NICE guidance right at the very front, it very, very clearly says this is at population level, and at individual patient level, we need much more of a discussion with the patient and the clinician based on the scenario that you find yourselves in. QOF also has the personalised care adjustment. So if you've got a person in their 80s where together you've come to the decision that actually you're going to stop a statin or you're going to lower their blood pressure medicines, you know, those challenges around QOF, there is a sort of an exemption. And I know there's some issues around that, and we can perhaps pick that up later on. But I talked to you about the economic argument for doing it at sort of global, you know, NHS level. It's very clear. NHS Scotland have been working on doing structured medication reviews in a selected group of patients who are the patients I've just talked about. And they've demonstrated that per SMR, there's a saving in terms of the drugs budget, and there's also a saving in terms of avoided healthcare resource. Ireland, where the pharmacists are not yet prescribers, have proved something similar. And Dorset, who are able to measure this, have been able to identify that their SMRs in over 75s on 10 or more medicines has led to savings in terms of the drugs budget. But for me, this is all about medicine safety. A nice side effect, if you like, is that we make some savings and those patients don't need to come in and see us as often. But the goal has to be, particularly for our frail patients, that we're making sure they're on the right medicines and not on any medicines that are going to make their frailty worse or give them, more problematic symptoms as they reach their sort of very later years. In terms of patients, then, we know from research done in Leeds and Bradford that patients often are confused about what an SMR is. So they get an AccuRx message that says, come for this appointment. They don't always know what it is, so they don't turn up. And when they come, they sometimes feel a little bit reticent in terms of sharing their ideas, concerns and expectations around their medicines. They might not be honest about which ones they're not taking. And so this research kind of highlighted we need to do a few things. We need to make sure if we stop a medicine with a patient, they're really clear about why we're doing that. And older patients in particular, particularly if years ago they were told by someone, oh, you have to take this for the rest of your life. They say, well, why are you stopping this medicine now? And we have to explain to them it's not because you're 82 and we don't care. It's because you're 82, your kidney function isn't what it was. And we know these medicines aren't great in older people. And we think actually you now might be better on either a different medicine or not that medicine at all. They talk about feeling abandoned sometimes. So a medicine stop, but they don't know what to do if the symptoms come back. And they're also confused about why sometimes they might see a GP and other times they might see a pharmacist. So we've got a lot of work to do to get over that. And we've been working with the researchers in Leeds and Bradford and with patients. And we've designed this suite of materials that some of you are now using to both invite patients to their SMR, to help them understand what questions to ask in their SMR. And if medicines are stopped, you can see that on the right-hand side, that Stopping Medicines Safely leaflet is proving very, very popular. And we know, and these materials are freely available to every practice, we know that where they are being used, particularly in areas of high deprivation, where traditionally we struggle sometimes to reach certain groups of patients, we're seeing a number of things. We're seeing more patients turn up for their SMR. We're seeing a decline in the number of did not attend rates. And we're also seeing an improvement in the quality of those SMRs. And pharmacists who've been doing this for a long time are describing, finally, the patients kind of telling me what's happening with them. So nationally, we've been funding PCNs to work with us, PCNs in core 20 areas. So we've got, and locally, we've found some money to support a small number of PCNs to work with us to roll these materials out, and very grateful to all of those practices there who've started that process with us. But if you want to use the materials, they are available. They're in Ardens, or I'll put the link in the chat later on. They've been translated into a number of different languages. So if you've got populations where English isn't the first language, you can use those materials. There's a QR code with a recording. There's easy read versions. We've tried to make it as straightforward as possible. So if you're currently not using any materials to invite people for your SMR, you're missing all of that opportunity to get patients in and then have a really good conversation. Whereas just getting the text message saying, come for this appointment next week, patients are left very confused as to what that is. So in terms of how we address polypharmacy at PCN level, we've got a very strong and growing evidence base that tells us exactly what we should be doing. First of all, we need to use the data to find the patients who are at risk from harm. You can't see everybody. You need to strategically kind of prioritise those patients. Then use the materials to invite them for a medication review. So you've got the best chance of the patient turning up in the best possible frame of mind to say, actually, I am worried about these blood pressure medicines. They do seem to make me a bit dizzy when I stand up. Then make sure that patients kind of really are engaged and ready for that, and they'll come to expect it, year on year, particularly if they're in those high risk groups. But it's important that our workforce understand how to do good SMRs. And if you were in that bracket where you filled in for Kerry, not confident or still getting there, I would urge you to come on the Polypharmacy Action Learning Sets. We have GPs and pharmacists, and it consists, we've been doing it for about 6 years now. We are consistently reviewed, and people say it's grown their confidence to tackle what we know is a really challenging area. And then finally, measure the impact of the work you've been doing. So I said at the beginning, I would just quickly revisit repeat prescribing. I always say all polypharmacy roads lead back to poorly managed repeat prescribing systems. And we know over the last 20 years, repeats have just sort of grown exponentially. It's incredible what practices and pharmacies actually manage to churn out every month. So we've been working with the RCGP and the Royal Pharmaceutical Society. This was just published last week. It's the Repeat Prescribing Toolkit. It was a recommendation of the National Overprescribing Review. And there isn't a huge amount of time to talk about it now, but it's a self-assessment. It's not guidance, it's a toolkit. It's for you at practice level to have a look and go, what do we do locally and how might we be able to improve, particularly around medication safety? At the same time that it was published, we also published some data showing where medicines might be oversupplied. Now, it doesn't cover all medicines, but it covers statins, antiplatelets, blood glucose testing strips, and a number of other medicines, particularly where there's a sort of daily or recommended dose. This is a snapshot of the data from Hampshire and Isle of Wight, and you can see this is just for statins, just looking at July. We've got nearly 300,000 patients who get a statin. Of those, the pale blue area is people who get about 12 months supply. So this is every month, and you can see it goes up to 13 months. So within 13 months, those patients have had 12 months or 13 months supply of their medicine. In the dark blue, you can see they've had much more than that. Now, obviously, there's quite a few people in this bracket, which is the dark blue, just that side of the 13-month supply. But we've got 10% of patients in Hampshire and Isle of Wight who get more than a year's supply in a 12-month period of their statin. And really worryingly, we have nearly 1,000 patients who receive 2 or more years' supply of a statin in that month, in that month that I looked at. So if you think of all the energy you put into doing your repeats, 10% of patients are getting way, way more than they need, and a small proportion, over 1,000 patients, are getting an amount that really, I think, is, it's hard to argue it's not a huge oversupply. We can look at that at practice level. So you can access this data and have a look. What does this look like for your practice? And you can see in Hampshire and Isle of Wight, massive variation. So we've got some practices who've got nobody in the oversupply bucket for statins. We've got some of you around 5%. It grows and grows and grows. And then there are a number of practices up here where 25% of all of your statins is classed as oversupply. And I hate to do this to practices, but it's important that you know what your own data looks like. You can see that variation there. Now, obviously, those practices near the top of that list, so where 25% of your statin prescribing is classed as over threshold, these are big practices, and I know you've got big machinery around your repeats. But I also think it's just worth remembering that means a quarter of the times you're signing off statins, you didn't need to because the patient had enough supply. And maybe by tidying up those systems, you would make things safer for patients, but also reduce some of that unnecessary workload. So finally, for me, we're going to talk all afternoon about SMRs, but they are the intervention to support patients to take only the medicines they need and stop any that they don't. It couldn't be more important. There are lots of groups who are exposed to polypharmacy, people with learning disabilities and others, but the group who are probably exposed the most and receive the most harm are our older people with frailty, with multimorbidity, where we owe them more than some of the reviews that they get. SMRs are hugely variable, but we now, through the programme we've been delivering, have an evidence-based set of resources to help you do it well, whether that's in terms of inviting patients or your own skills to do what is a complex area of work, and there's no denying that. So I hope that gives you a sort of picture of what's out there. We know this isn't easy, but as we go through this afternoon, hopefully you'll get lots of hints and tips as to how we could do this a little bit better. So I will stop there, Kerry, and stop sharing. And I think we're handing over next to Kinder and to Eloise.
Thank you, Claire. Kinder, did you want to share your own slides, or did you want us to do that for you?
We can share the slides. I think Eloise is going first. So, Eloise, are you here?
Yeah, I'm here. I'll share my slides. Can you hear me?
Yes, that's perfect. Yeah, we can see that.
Great. And can you see?
Yeah, you're just not in presenter mode. There you are. Yeah, you're a little bit quiet, Eloise, but we can see you and hear you.
Try and speak up. Just tell me if you can't hear me at all. Okay. Yeah, so a lot of this ties in with what Claire was saying, so that's great. So I'm going to present today on our study, the Multidisciplinary Structured Medication Review and Deprescribing Intervention in Primary Care for Frail Older People Living with Polypharmacy, or the MODIFY study. It's funded by ARC Wessex. I'm the Senior Research Fellow on the study. Eloise Radcliffe got a background in social science and an interest in older people, long-term conditions and medicines optimization. I'm presenting on behalf of our large research team that includes Claire Howard and Kinder Ibrahim, who's leading the research. So as a bit of background, and a lot of this ties in with what Claire was saying, so I won't spend too much time on this, but polypharmacy amongst older people with multiple long-term conditions is obviously a growing local and national issue, highlighted very well in the AIDS UK report from 2019, More Harm Than Good. Polypharmacy creates a high burden for patients, carers and the healthcare system as a whole, as we were just hearing, and a third of older people have polypharmacy. And inappropriate polypharmacy obviously increases the risk of side effects, hospital admission and death. And as Claire was saying, there's a higher risk amongst people living with frailty. And then the overprescribing report, also mentioned by Claire, obviously makes reducing overprescribing and addressing polypharmacy national priorities. So the NHS long-term plan recommends annual structured medication reviews in primary care to identify and reduce or stop inappropriate medications with the goal of improving outcomes or deprescribing. And as we were just hearing, there are significant challenges to this on a systems level, and the way in which SMRs are carried out is very variable across the UK. So evidence suggests that shared decision-making and a multidisciplinary team approach facilitates successful deprescribing, but obviously this is also very challenging in practice. So the aim of this study was to design a multidisciplinary medication review and deprescribing intervention in primary care for older people living with frailty. So I'm just going to talk a bit now about the work that we did to develop this intervention, and then I'll go on to talk about the intervention itself. So we carried out a review of the evidence. So we looked at interventions that had a multidisciplinary element. So that's 2 or more professionals working together, which tended to be pharmacists and GPs. And then the interventions also had to have a deprescribing element as well. And these were for older people in primary care. So we identified 28 interventions, and there were a few UK studies, but they were mainly from New Zealand, the Netherlands, USA and Canada. So we were really looking at identifying what worked well in terms of multidisciplinary medication reviews and what didn't work so well. Then in addition to this, we carried out our own qualitative study. So I carried out focus groups and interviews with 26 healthcare professionals from 8 general practices across Wessex. And then a qualitative study as well with patients, 10 patients and 3 of their informal carers, so older patients on 5 or more medicines. So moving on to our findings. So we published in BMC Geriatrics last year, but I'm just going to present a summary of our findings now. So these are factors that facilitate multidisciplinary medication review and deprescribing. So there are 4 main themes. First of all, healthcare professional roles, responsibilities and relationships. So clearly defined roles and responsibilities of MDT members were really important. Integration and co-location of pharmacists in primary care, taking a lead role in the medication review process. Use of different expertise in the team for delivering different elements. And then trust and a good relationship between team members was really important. And the second theme, healthcare professional training and education. For example, targeted training on deprescribing and shared decision-making was important. And then the third theme, involvement and education of patients and informal carers. So as Claire was talking about, patient attitudes, perceptions play a really key role, and trust. So education for patients on the purpose of the medication reviews was really important. For them to understand the rationale for deprescribing, and also the role of clinical pharmacists. So many patients were not familiar with the role of clinical pharmacists in primary care, as well as the purpose of medication reviews. So a focus on patients' preferences and priorities was really important as well, and where appropriate, the involvement of informal carers. And then again, trust was really important. So trust between patients and healthcare professionals. And there were a few ways to approach medicines reviews and deprescribing with patients that could build that trust. For example, starting as a trial of medication that could be restarted, or starting with quick wins that could sort of build up the rapport with patients by stopping a medication that was relatively simple to stop, that the patients would see the benefits of, and then doing this slowly over time, and also focus on safety rather than cost. So, you know, as Claire mentioned, many patients believe that medications are being stopped because of saving the health service money. So it's just about reassuring patients that this is not the focus. Okay, and the fourth theme was the format and process of the medication review. So the efficiency of the multidisciplinary process was important. So as Claire said, it's important to have systems in place to target high-risk patients. Accessible and easy to use deprescribing tools to facilitate decisions was important. Good communication between team members, for example, using digital tasking systems, and then preparation for healthcare professionals to increase confidence in their decisions. And then the mode of communication. So face-to-face appointments were ideal for facilitating shared decision-making, but the approach should be tailored to the needs of patients and carers. And then lastly, follow-up support. So as Claire mentioned, patients can feel abandoned. So it's really important to provide written information for patients to take away with them of any changes that have been made, and then scheduled follow-up if it's needed to monitor patients and address any concerns, and this facilitates continuity of care. So with our findings, we then developed guiding principles for an intervention. So we used a theory-based approach. So we used a person-based approach, drawing on the COM-B model of behaviour change. So this was about capability, opportunity and motivation for behaviour change, which is rooted in psychology. And then we also used a normalization process theory lens, drawing on sociology. So we developed the sort of prototype of our intervention. And we conducted 6 co-design online workshops with key stakeholders. So that was 25 primary care staff, including clinical pharmacists, GPs, frailty nurses, a variety of different primary care staff from across the UK, patient and care representatives, and our research management team. So at these stakeholder workshops, the intervention guiding principles were presented, the intervention content and format and delivery were proposed and discussed and continually refined through an iterative process until we had our final version of our complex intervention. So this is what the final intervention looks like, and there are 5 main stages. I'm not sure how well you can see this on your screen, but I'm going to go through each of the stages now. So the first stage is the proactive identification of patients for targeted medication review. So we developed searches for practices to use. So this was based on the Electronic Frailty Index. So we identified patients who had moderate to severe frailty, aged 75 and over, and prescribed 10 or more medications. And we excluded those at the end of life and in care homes. And then the second stage was patient and carer preparation. So these were the resources that Claire put up in her presentation. So they were obviously developed with Bradford, and they were evaluated previously. So we're using these resources to prepare and educate patients about the purpose of a medication review, the reasons for potentially stopping or changing medications, and then there's some questions to think about beforehand. So this was sent to patients before the medication review. And then the third stage of the intervention was
the healthcare
professional preparation. So we were very flexible with the intervention. So it was designed to be delivered by any prescribing healthcare professional, whether that was a clinical pharmacist or a GP or someone else. So we developed evidence-based tip sheets on ways to approach deprescribing with patients. And also, as part of this intervention, we are using the Prescript Impact tool. So I'm sure many of you are familiar with Prescript. They are a community interest company funded by the NHS. And this is an online tool for identifying and prioritising high-risk medications for deprescribing. So it produces an individual patient medicines list where it prioritises high-risk medications for deprescribing, and this can be used in discussions with patients to make shared decisions. And it's obviously used to support clinical judgment, and it brings together different sources of evidence in one place. And we had very positive feedback on this during our workshops. Okay, and the fourth stage was conducting the actual person-centered medication review appointment. So again, we were flexible with this. It could either be in person or on the phone, tailored to the patient and carer needs and their preferences. And it would involve other multidisciplinary team members based on their experience as and when needed, for example, with particularly complex patients if needed. And then any changes made to medicines were documented and shared with the patients and other team members, which brings me on to our final stage, which is the tailored follow-up plan. So again, this is, I think this is one of the resources that Claire just showed in her presentation, also developed and evaluated by Bradford. So this is a template that can be used to document any changes made to medicines, highlighting specific signs and symptoms for patients and carers to monitor. And then there's a space to record any planned follow-up appointments, whether this is phone or in person, and this will facilitate continuity of care. So we've developed our intervention, and we're now carrying out a mixed method study in primary care to test the feasibility and acceptability of this intervention. We've recruited 5 general practices from across South East England, so a range of practices from different areas, and we've successfully recruited 47 patients, so we were aiming for between 40 and 50. And we've collected outcome data at baseline, and we're currently finishing off collecting our 3-month follow-up data for these patients. And we've also conducted a qualitative process evaluation with a sample of patients, carers and healthcare professionals delivering the intervention across all 5 practices to understand a bit more about what worked with the intervention and what could be improved. So I'm just going to talk very briefly now on the feedback that we've had so far. So patients gave really positive feedbacks on the medication review appointments generally. They really appreciated the longer appointment time, so they were generally half an hour, and they felt that they were given time to talk about their concerns and time to ask any questions that they had. They really valued the face-to-face aspect of the appointments and the opportunity to know what each of the medicines were that they were taking. For most patients, at least one change was made, whether that was a reduction in dose, switching or tapering and stopping a medication. And then for those patients who have follow-up contact, they really valued this. And I've just put in a brief quote from a female patient who had tapered one of her pain medications and had stopped it and was now moving on to stopping another medication. And she said that participating in the study gave her food for thought. Before, a medication review was a tick box exercise, but this made me think I have every right to say what I thought. The pharmacist listened to what I said about what I was taking, what I wasn't getting any benefits from. Why am I putting this into my body? We made a plan as to what I wanted to come off of. We agreed at the end, and what we were going to do, and that she would call me on a regular basis. Okay, and just 2 more slides, I think. So the healthcare professional evaluation. So the senior and junior pharmacists delivered the intervention with the support of GPs. The appointments were mainly in person, and they lasted about 30 minutes. And then the pharmacists had 15 minutes beforehand to prepare using the Prescript Impact tool. We had very positive feedback on the tool. It was used for prioritising medicines for deprescribing and as a source of evidence to explain reasons to patients. And there were a lot of suggestions to embed this as a template in System 1 or EMIS for ease of use and access. And then I just put in a brief quote there from one of our pharmacists who is delivering the intervention. She said she found resources very helpful, and this has allowed her to engage with polypharmacy work through proactive reviews, which she wasn't doing before. So the study has definitely highlighted that we have lots of work to do at the practice, she said. So in conclusion, we've taken a rigorous and systematic evidence-based approach to our intervention design, drawing on behavioural and implementation theories to maximise the modified intervention's acceptability, feasibility and potential effectiveness. Now, our next steps will be to carry out statistical analysis of our baseline and 3-month follow-up data, and then health economic analysis. And the aim would be to test Modify in a full trial in future. And that concludes my presentation. Stop sharing.
Thank you,
Thank you,
Eloise.
Eloise. Are you happy to hand over to Kinder?
Yeah.
Thank you.
Can you see my slides?
Yeah.
Okay. Brilliant. Okay. Thank you, everyone, for joining this afternoon. So I am just going to carry on where Eloise left. Just to introduce myself, I am Associate Professor in the Faculty of Medicine in Southampton, and I'm a pharmacist by background and training. I'm very interested in medicine optimization, polypharmacy, and e-prescribing, and lead a number of projects on this area. One of them is Modify study, which you just heard about. But in the next few minutes, I'm going to talk about other two studies that we also did in Southampton. And one of them was looking at how we encourage and improve shared decision-making around medication with people with dementia or mild cognitive impairment and their carers. So that's the stop there. Okay. So it's in the UK, we know that almost 60% of people who have dementia live at home and cared by their family members, and normally it's their spouse. Most of the people with dementia take multiple medications, and they have multiple other chronic conditions. And we know medicine optimization in this population is very complex because of the reduced mental capacity of the patients. There are challenges in communication and increased involvement of carers, which make it sometimes hard to really establish the goals of treatment and care, especially if you have patients and carers who have maybe different goals. So the aim of this study was really to understand how medicine optimization is done in this population and what can be improved, or things that need to be considered when medication reviews are done with people with dementia. So we did a systematic review to look at the evidence actually of de-prescribing intervention in this population. And we identified 32 papers, which I'm going to very quickly summarize in the next slides. We also did a qualitative study, so we did interviews with people living with dementia and their carers, and we used also photo elicitation methods to really help people with some cognitive impairment to express their daily experience with medication through using taking just photos that represent their experiences. And we did also interviews with primary care teams, that's nurses, GPs and pharmacists, and older persons, mental health practitioners. So just quickly looking at the systematic review. So most of the interventions were either medication review alone or medication review with element of healthcare professional education. And the vast majority were in long-term care or residential care, and we found only 2 papers were done in primary care, which really shows the gap that people who live at home are really being excluded from the evidence that available. So this is a very complicated table, but I just wanted to highlight that these are the main outcomes reported in the studies. So the main outcomes was medication-related outcomes, but there were also some clinical-related outcomes like falls, quality of life, and cognition, and some safety outcomes. So just quickly, in terms of medication-related outcomes, it seems like the intervention, regardless of the type of intervention, whether it was a medication review or education, led to a reduction in a number of medications or potentially inappropriate medications. And most studies actually looked at psychotropic medications and what they were in long-term care. In terms of clinical outcomes and safety outcomes, they were investigated less often, and the effects on falls, quality of life, and cognition were mixed, with some studies showing no effects and others showing maybe some improvement, but it's hard to really make any conclusion because of the limited number of papers reporting on these outcomes. In terms of safety, it's been agreed actually internationally that no changes in hospitalization or in mortality to be seen as positive outcomes, so indicating safety. So in the studies, only 4 studies reported hospitalization and mortality, and it seems to show no difference in the outcomes between those who received medication review and those who didn't. So just to summarize the findings from the review, we found that most of the intervention focused on specific drugs, antipsychotics. They were limited to inpatient and nursing home settings, and the outcomes that were reported were medication-related outcomes. And we looked also in the studies to see if the patients with dementia and their carers were involved in shared decision-making, and it was really hard to report that from these studies. So moving on to the qualitative study, so we did, so most of the findings that we found from the MODIFY study were really common in the study as well, but I tried to highlight very specific elements or themes that were very much related or unique to the people with dementia. So the first one was navigating patients versus carer versus professional voices. So in general, it felt like, or it was reported that changes about medications or decisions about medications were very much professional-led. And there's appetite for more involvement in patients and informal carers in these discussions. But at the same time, there was a recognition that patients' ability to understand the information given to them and their cognitive abilities should be taken into account. So the main thing here was although carers were very much keen to be involved in decisions about education, and they were seen to be the right group of to be involved because they can relay information to the healthcare professional about how the patient's managing medication at home, but at the same time can support patients with any changes agreed with the healthcare professional after the medication review. Some patients felt that they were not heard and their voices were really ignored during the medication review process. So there was a need really from the views that we had, that the patients and carer dynamics should be really established and understood by the professionals doing the medication review. And when possible, if the patient is able to understand information and be involved in decisions, they should be offered this opportunity. And also sometimes there are the conflicts when you have patients and patients. So for example, one of the examples that were mentioned, sometimes patients are denial of their memory loss. So when the healthcare professional asks them, how are you managing at home? How are you managing with medication? They would say, yes, I'm fine. But when the carer is trying to correct this information in front of the GP or the pharmacist, this might raise some conflicts between the patients and the carer. So there was some discussion on having a way or a process that carers can share the information with the healthcare professional who is doing the medication review without having not in front of the patient, and that could be maybe sending this information by a text message or a letter before the medication review. So in terms of people with dementia, the process of medication review needs to be flexible. So because of the changes in cognition and the fluctuation of the health of patients, they felt like having an annual review of medication maybe not suitable for these patients, and there should be an opportunity for patients to request medication review when they feel it's needed. And it needs to be accessible. So lots of patients and carers talked about having a named person in the practice who can maybe answer questions related to medication or be the first port of call if they needed to book an appointment, or if they have a quick question about a side effect. So they don't maybe need the whole medication review, but they needed just someone knowledgeable to answer these questions. And lots of carers were very keen to involve all the people's mental health teams in any decisions about medications, mainly because they felt these teams were more knowledgeable about dementia and the condition itself, and they might input and provide like a different insight. And again, as Eloise mentioned earlier, involving a follow-up after the medication review to understand how the patients and the carers are doing, and especially if decisions being made to stop or change medications. So what would facilitate the de-prescribing discussions during the medication review? Having this open conversation style where you're explaining the purpose of each medication. So lots of patients felt they don't know why they are taking this medication, and the same for carers. So understanding why each medication is given and the benefits and risk of carrying on or stopping a medication should be really tailored to the patients. Also, patients talked about maybe the way the information is provided should be thought about. So whether you can use some risk tools, risk calculations to like relay the information about the risk and benefit of medications could be useful. Having visual diagrams or representations of information could also help patients make sense of the information given. Again, I think continuity of care is always coming up every time we talk about medication review. So whoever is doing the medication review needs to build a rapport with the patients. They need to know, and specifically for people with dementia, they need to know the patient and the carers, and they need to who needs to trust them to really make any decisions about their medications. The right context, so for people with dementia, it's definitely seems to be people like prefer the medication review to be face-to-face. It needs to have allow enough time to really to get into the depth of what's happening at home and how people are managing with their medication. And people talked about having familiar environment and whether this could be done at patient's home or maybe somewhere they feel calm and more relaxed. Again, I think one of the highlight or one of the things that I would like you to take from this presentation today is providing written summary of any agreed changes or medication changes that you have agreed with the patients and carer following the medication review. So sometimes even the patients, if they understand what you have told them to do during the appointment, they might forget later. And the same with the carers, they have lots of other responsibilities. The care burden is high. So relying on their memory to remember everything being discussed is challenging. So they really valued having a written summary or agreed management plan that they can take back home. They can read it later or share it with other members of the family and action it later on. So the last theme that I wanted to highlight is for people with dementia, we need to consider how any changes in medication can impact on their routines. So people talked about having routines and aids and reminders that helps them remember to take their medications. And how we need to consider when we do any changes, whether these changes can affect the routine or disturb the routine. And so it's really important when you do the medication review and when you agree a change in medication to ask the carers and the patients how that can fit with their routine and whether they need any support really to help them with embedding the new changes in their daily life. And some carers talked about how this can, the medication review, or when they come out of medication review, this can add to the burden that they have because they have to really sometimes liaise with the community pharmacy about ordering the medication, or they need to do changes in the home setting to really integrate these changes into their routines. So it's really important to really ask these questions when we do the medication review. So I just wanted to summary and take home messages from this study. We used a theoretical lens called the Census framework, which is widely used in dementia research. And it highlights the importance of having a relationship-centered approach. So we talked about person-centered approach, which is very important to medication review, but also we need to think about relationship-centered approach in people with dementia, having this named contact, have continuity of care, and knowledgeable people who are able to give to answer any questions patients have or carers have about their medications. So provision of information after consultation to aid implementation of changes and help family members is key. Implement a process to manage patients' care dynamics. I think this is maybe challenging in consultation, but if you can identify whether the patients would like to be involved before assuming they don't have the capacity to be involved would be useful. And having a time and appropriate space to really explain to the carers and patients why these changes are being implemented. And when possible, if you can involve all the person's mental health to offer really and allow more holistic approach to the patient's care. So very briefly, I'm going to describe another study, looked at social prescribing and how we can involve social prescribing link workers in supporting people with after medication review. So lots of patients talked when we talk to them about deprescribing, they always mention, if you are taking something away from us, it's good to feel like there is something alternative. So if you are taking a medication, can we offer something else in return? And this study came about because the overprescribing report that was published in 2021 and highlight the importance of structured medication review in primary care had one of the recommendations outlined that appointments must be long enough to allow for shared decision-making, typically at least 30 minutes, and social prescribing link workers should be trained to help support patients after an SMR. So this was like a very interesting recommendation because we looked at the literature and we found nothing to really suggest that involving social prescribers could be useful or can be beneficial, and we didn't know how they can be actually involved. So so we got a small funding from School of Primary Care to really do a qualitative study to understand what is the role of social prescribers in SMR and what their training and development needs to be actively involved in this process, and what can they offer? So what are the alternatives to medications that they can provide to the primary care teams? So we just finished data collection. So we did interviews and focus groups with around 72 participants from across England, and these included health and social care practitioners, people living with polypharmacy, and their carers. And these are very preliminary results. So we haven't done really the analysis, but I thought I'll share some of the findings with you today. So there is a wide range of models that or variation across the practices in England in how SMR are conducted, but also how social prescribers are involved. And very similarly to what we found in our review in the Modify study, we found that even when we talk about social prescribers, that having good relationship between the team members, having well-integrated teams, clear rules, and an MDT type of environment were key features in practices where we identified have good models of care and where social prescribers were involved in supporting people getting off medications. The physical presence of social prescriber within the practices make it easier for patients to engage with them, and this accessibility enhances even patient trust and involvement in non-medical alternatives or non-medical interventions. So some examples of activities that social prescribers were leading or involved in reducing medicine use, some type of diabetes prevention groups, like diet group activities and exercise to really delay or stop people from needing to start on anti-diabetes. Pain management groups, so lots of practice talked about using social prescribers to reduce reliance on medications. They used peer support and having people with lived experiences, so people who managed successfully to stop painkillers and opioids were invited to come to these group sessions and share their lived experiences with other people who are considering stopping pain medications. Also, walking groups were useful, so using walking and exercising as a way to reduce pain medications. Other examples were reducing antidepressants by referring patients to social activities and weaning them off medications. And there were some other examples on fall prevention and COPD management. However, there were some challenges being identified by people, and especially by the primary care teams and social prescribers themselves, on the boundaries that people who have no medical or clinical background being involved in supporting medicines related decisions or supporting people following a medication review. And they felt even if social prescribers are to be involved, they need to be trained on how to talk about patients in relation to medication adherence, or identify any issues the patients that might have, like in terms of compliance or even side effects. So we try to prompt people to think about what would be the potential roles of social prescribers in relation to medication review. And there were some really interesting ideas came from that question. So they talked about the possible role of social prescribers in initiating conversations about medication with patients, because most of the time the social prescribers go to the patients' houses. They see sometimes the the patients in their real environment. They can understand how sometimes, and they feel more safe to share information with them. So they felt they are able to have these initial conversation with patients and identify those patients who might be suitable actually to signpost them back to the primary care team for a medication review, like people who maybe keep falling at home or stocking piles of medication boxes, which is an indicator that they are not taking them. They also talked about possibility of working alongside the clinical team to really wean people off medications. So because they have this closer relationship with patients, they were able to maybe, if a decision was to stop antidepressant, for example, the patients might be the social prescribers might be able to really support patients by taking, slowly tapering the medication and being there as a liaison between them and the clinical team. And also by offering non-medical alternative with new diagnosis, as I described in the an example of diabetes. So yeah, thank you so much for listening, and I am very happy to take any question. This is my email, so if you want to know more about what we are doing, or you want to hear more about the results, please get in touch.
Okay, thank you very much, Kinder. Sorry, my camera's off. I don't know if is Laura here, Laura Bryant? I can't tell from the invite list if you're here or not, Laura. Could you wave if you are? Oh, you are here. Lovely. Would you like me to share your slides for you? Would that be easier?
Thanks, Kerry. Yes, I'm on minus time, aren't I? But that's fine.
You are. That's okay.
We
can push the break. That's not a problem. Don't worry.
No, honestly, it's fine. I won't keep everyone. So hi, I'm Dr. Bryant, GP partner at Waterside Medical Practice, which, for those who don't know Hayling Island, it's a glorious place. And our PCN is made up of 3 practices currently. So I started out that journey as a deputy clinical director. I'm now clinical director as of July this year. And our journey has been, I wouldn't say without issues, and that's perhaps my angle for this brief talk. I can probably keep it all onto one slide, to be honest, and just talk about the rest. And if anyone wants to ask me questions about trials and tribulations of PCNs at later date, I'll pop my email in the chat. So you can see in the slide that we've had a lot of variation in our PCN. So our weighted list size in our PCN is just over 37,000, but actually our list size is about 32. So actually we're a heavily weighted population in terms of we've got a high elderly population across the 3 practices, and that in itself has had its challenges. So the 3 practices are very individual. We've stayed the same since we formed a partnership in 2019. So we had to put in our bid in April 2019 to become 3 practices that wanted to work in the PCN. And we had to hit that 30,000 target, as probably you all know. And nothing's really changed since then, which is actually the best thing. Because Kinder touched upon how well integrated teams are key, and I would 100% echo that. That has been a real challenge for us, how to create that environment where you've provided the training, the learning, and sustain that without that turnover of staff. So our recruitment started in August 2020. So there was a few months there where it took me. So I went out on a limb and wanted to work with pharmacists, knowing how excellent that MDT style of working can be for patients. And it took me a few months to get partners on board across the 3 practices, bearing in mind we're all very individual and we like to do things in very different ways. So that I was doing that in the background, and then we did manage to recruit at that point. So 2 pharmacists and a pharmacy technician to start with in August of that year. So we're really lucky, but none had any primary care experience. So that in itself took a long time to embed. We're having weekly, so I invested a lot of time I've invested a lot of time since then. So I've been supervisor for all of the pharmacy team since our inception in August. Then alongside that, I worked with one of our pharmacy technicians who was intrigued in research. So the panoramic trial we joined in October 21. So that was looking at COVID positive patients that would be eligible for antivirals. And that really started my research journey alongside the pharmacy team. So that was really as an aside. And then building on the success of the work of the pharmacy team, we actually expanded, so we recruited 2 more pharmacists and another pharmacy technician in that March of 2022. I just wanted to touch upon the politics of PCNs a little bit, because I don't know how much people understand the difficulties PCNs faced in that time, because you went from a 44-page document of our PCN DES in 2019 to a 104-page working document in 2020, and then 21 it went up to 116. So you can see the workload, and it's not as if, and I don't get me wrong, I love places like the King's Fund and London South Bank. They're the think tanks, aren't they, behind all of NHS England's policies. Don't get me wrong, I think it's heroic what they try and set out in these contracts, but actually ground level, you're looking at me, myself and I implementing these things, because actually you've only got a few GPs that are interested in growing and change and adapting to new ways of working. So as you can see, and then that really links on to the rest of the timeline, because what's happened is that we've built the independent prescribing abilities of our pharmacy team, and dealt with 2 independent prescribers. We're about to have a 3rd finished hopefully soon, but that in itself has taken an inordinate amount of time to develop in terms of those skill levels. So something I won't witter on, and sorry, Kerry, just butt in if I do witter on, but I just wanted to really just to touch on the fact that to grow a team takes a long time, and to grow the training and the expertise in that team takes even longer, as you've probably all gathered from your own working environments. But I think having people invested in that has been challenging. So yes, it's lovely to have our team members that are now independent prescribers. We've got one of the same pharmacists and one of the same pharmacy technicians since the very beginning, who I really lean on for developing new ideas of working. And for example, the Modify study, just had to ask one of our pharmacists and say, look, do you mind giving this a go? I think you'll enjoy it. Eloise and Kinder are great. Let's try and work with them a bit more, because we were developing our research at that time. And so where we are now is, so I would say actually it's been a journey of probably about 5 years of getting to this well-integrated team status, because our SMRs has been very hit and miss, I'd say, because we've had issues with estates, staff turnover, training, you name it, absolutely everything is gone, come and gone. But in that time, and you can look back now, it's quite nice to do the time actually we have achieved quite a lot, because we've got some wonderful members of our pharmacy team, and who are all now highly trained, highly capable, and we're hoping to lead on PCN research. So it's as I say, it's lovely that NHS England have got these great ideas on SMRs and how to hit IIF targets, but on the ground it is difficult. And you've got, and I think all of our pharmacy team is saying the same thing, that unless you've got that support from GPs around you who can debrief with you and say, oh, did you know about so-and-so's new heart failure presentation, rather than it just being their AF, something like that, you can bounce things off of each other and go, oh, you know, they're now housebound, they're not able to come to the practice. You need that support system, and it takes a long time. But what I would say is we're now in a really good place. Estates is now sorted, so that took me 3 years to get some more clinical rooms built. So it wasn't just a case of not having this space. We had to create the space to allow our pharmacy team to have a clinical room. So things like that that you've probably all experienced, but I just say that's been our journey. And yeah, if you want to reach out to any advice, I can probably give lots of words of advice in how to navigate that in the future, if you want any support.
That's great. Thank you so much, Laura. didn't change slide. I hope that was okay. I think the timeline sort of summed it up really nicely. So yeah, thank you so much for that. We're going to take a quick break. So if we just have 5 minutes and everyone comes back for past, and we'll then be joined by Lawrence Brad, who's our other GP speaker today. So just 5 minutes and we'll be back then. Thank you.
Kerry, are you there?
I am.
Hi. Do you want to? I don't know. Have you got? I don't know this slide. Have you got my slides there? It might be.
Yes,
more
I will
efficient
have
for
your
you.
slides. Yeah,
Can I just check the first slide? Do you mind if I just check? Because when I was sending them through, for some reason, my first slide was invisible, but then I sent through. That's fine. Okay. So
Yeah,
I'll just go let you change them. Is that all right? It will just speed things up a bit, save me sharing, won't it? Okay.
Yeah, no, absolutely no problem at all. Yeah, no problem.
Kerry, the one other thing is I might just have to head off fractionally before the end of the meeting, I'm afraid. I probably have to clock off at 3:15, so I might just miss some of the questions and answers, but Claire Howard invariably would know most of the answers to any of the questions that you might ask me.
That's fine, no problem at all. I think actually, because it's in the Q&A, I think actually Claire is doing an admirable job of actually answering the questions as they appear, so it's working quite well, actually.
I wasn't sure if that was annoying when other people were speaking, but I thought actually there'd be too many at the end, so I'll try and just keep going. But yeah, I'm pretty sure Lawrence and I have worked together so long, I think I know what you would say.
I think you can answer most of my things, yeah.
No, I think it'll work out quite nicely, actually. And we were thinking that sort of bought us a bit of time, actually, if we answer lots of the questions if they crop up. That's actually
okay.
fine.
I'll keep doing that until you tell me otherwise.
Thanks.
No, we were both saying how helpful it was, Claire. Thank you.
Right, we'll let everyone reappear. It's difficult to know. I'm assuming everyone's behind these faceless.
No, I think because obviously time, we are going to stick to time, so we'll be restarting again at past. So a few more seconds.
Yeah, this screen is really just our first prototype of some of our new patient-facing materials around overprescribing. It will be seen by a proper graphic designer before it goes out, don't worry. Okay, I'll hand over to you then, Dr. Brad. Thank you.
That's fine. Thanks ever so much. I've got 10 minutes, and this is just how I think with my GP brain a bit. So just taking on board what Laura's just said, I think I've been really lucky. So I think we've had a bit of the opposite situation to Laura, and we were at 30,000+ PCN with 2 sites, and for various politics, as everybody knows, one of the practices then had to close down. So we've ended up as an urban practice with 22,000, just all on one site as 1 PCN, and with quite elderly demographics. And I think it's just this concept of I like just to have a think about a plan. We've been in this game doing polypharmacy and deprescribing and structured medication reviews for quite a few years, and I was very lucky in that we appointed a very skilled clinical pharmacist early on, so it was so much easier for me as prescribing lead. So I was blessed. The clear narrative, I mean, I just think, you know, we've got the National Overprescribing Report, the Chief Medical Officer's report, so we've got a clear narrative about why we need to do this work in primary care. Claire's talked about the data, so we're blessed with brilliant data from the NHS Business Services Authority, so that's fantastic. So the nitty-gritty bit is just getting the right team and the right tools in place in practice to make this work. It needs the education that we've talked about with the action learning sets, and we really should be demonstrating some improvement with this, and we can do that by mapping, just as Claire showed, you know, with the data. So the next slide. Just one thing, I just think this is a great way, if you're just trying to think what should a structured medication review process look like, the 4 Ps here, you know, it's critical to prioritize the patients because we've got limited resource and we really need to get the most bang for our buck. The preparation is key to this because that is absolutely key. It's preparing the patients for it and preparing the clinical pharmacists for this. Patient-centered care and agreeing a plan. And our experienced pharmacist, his plan, he is PLAN. I think he says prepare, listen, agree, and note it down in the notes. But without doing that, then it won't work. And it's really worth doing this properly, I think, is the message I want to say. The next slide. And I think just for what it's worth, I mean, I would say now it's become a little bit overwhelming, possibly because there's so many tools out there that I think the one thing I would say in the team is you just need to you know, be sensible about it, don't you? And just say there's 2 or 3 tools that we're going to really use, or to have a knowledge of the other ones. But I can just imagine people getting very bogged down and spending hours looking at lots of different tools. So the next slide is really just, I think, you know, I'm not an expert on structured medication reviews, but the Scottish 7 steps one, I think now there's some quite good evidence behind that through the iSympathy work that was done in Scotland, where they use that as a way of doing a multidisciplinary patient-centered medication review. So we kind of know that that works. And just as Eloise has been talking about the impact tool, and the next slide is also just a bit more about that. I think it does have great potential, the impact tool, because it does kind of bring everything together under one roof. It's possibly a little bit more clunky, and the dream would be if that could be integrated in the clinical system one day. I think that'd be really good. And it probably is slightly more helpful for people maybe with a bit less confidence and less experience, perhaps, than maybe super experienced pharmacists doing that. But that's just an observation that may or may not be true. Next slide. So really, this is about the triggers. Just how do you really make it work to have your structured medication reviews in your practice or PCN? And this is just it's very obvious, but it's just worth reminding people. I think a lot of the documents and the contractual stuff say about being proactive. So proactive is still the #1 gold standard, I think. But there's 3 types of reactive at least. One is when there's a crisis or something goes horribly wrong, and that means somebody needs to be looked at more closely with their medicines. The patient themselves is highlighting concerns about it, or other healthcare professionals just think there's something not quite right and it needs a review. So that's a good example of just the basic calls of triggers for these things. The next slide. So we decided, this was quite a few years ago now, when we started doing structured medications review, where I was lucky with a very experienced pharmacist. We just took a view that we knew what the pharmacist team looked like. So this is our urban practice, about 21,000 patients, and we based it on 44 weeks a year, allowing for leave and everything else. And basically, if you look at that, there was 3 pharmacists, one in a care home. And if you look at that, we just took 7 sessions out of a total of 24 sessions within a week. So it's really just a third. So the rest of the time, the pharmacists are doing all the day-to-day stuff. So it's not taking out a huge chunk of time. And that gave us a number of sessions per year. So that was our supply. We knew that that was the amount we were prepared to offer to this process. The next slide is, so what is the demand? How many patients are we going to try and fit into this process? And again, I can rattle through this pretty quickly, but you just have to trust me with the numbers, I guess. But, you know, 10 or more medicines in our PCN, that wasn't a huge number of patients, but once you get to 8+ medicines, that was 662. And then obviously you want to look at some of the more high risk combinations and groups, or the high anticholinergic burden score. And some of those will already be within that 8 group anyway. But basically you can see, as a rough overview in our practice, we were looking at about 740 patients in these groups that were considered high risk enough to need a structured medication review. And the next slide, you got a little bit more from actual local prescribing quality schemes. So if you blend that in, that picks up a few more patients again, which is another 148, and it will be different in every region, but that's just the Dorset example. So what you end up with on this next slide is you've ended up in our situation with 888 patients. So if you divide that up into the sessions, that's 222 sessions. And you may remember, if you're observant from before, we'd already allocated ourselves 308 sessions per year. So the next slide. So that was really where we got to, and it works, and it's worked for a few years now, and it works really well. So we were working around 80% of our SMRs being proactive, risk stratified patients coming in, but you're allowing 20% of that time for those other triggers that I showed on that slide. That's worked for us, and I know, you know, everywhere is different, and you know, we've got one of the facilitators on our Action Learning set who's very into this, but her ratio is almost the opposite in Southampton, where she's more like 20% proactive and 80% reactive. So everybody's going to have a different blend of how this looks. Next slide. And of course, the whole key thing about this is it's important work. It's really quite detailed work. So it's just making sure it's all recorded properly, because we do want to be able to audit this and make sure we're doing the right thing. So however it's recorded, it's just doing it properly. And it's also this thing about making sure it's easy for the rest of the team to see what's going on. The nightmare cases where somebody's done some really good deep prescribing and then somebody's not really looked or understood why it happened, and then it all gets added back in at a later date. So recording it's critical, and making sure it's clear to others in your team is critical. Next slide. So this is really just to say that in Dorset, the bigger overview, it was clear there was a lot of variation between all the practices, you know, within PCNs and between the PCNs about the quality, I guess, and the accuracy of the SMRs. Now, some of that just down to really poor recording of these things in the first place, and some of it was clearly people were ticking an SMR box when actually they probably weren't really doing one properly. So this was our PCN, and what you can see is, you know, if you like to say that's sort of accuracy or completed, you know, within specification, if you like, so we know we're trying to target the right people, it's looking at sort of 82 to 96%, which is hopefully pretty good. And if you just compare that to the next slide, which was Dorset overall, I'm just quickly looking at numbers. Basically, those bottom boxes, it was more like sort of overall in the Dorset, about 73 to 80% we're hitting the sort of people you really want to target. So it is important. It's, you know, it's like everything. It's a whole mixture of things comes into this, but it's the recording and it's actually doing it properly and making it worthwhile. And I think the final slide is just to say that, you know, in Dorset, the DICE, the intelligence system, the Dorset Insight intelligence system, which everybody's going to have better population health stuff in their areas. You know, that bottom line is just by working with practices to make the whole process a bit easier and embedding the searches into the system, so it was easy to get the patient list up and get the recall going. Just over a year when they concentrated on it as a bit more work in Dorset, the change in accuracy was going up from, you know, comparatively low, he said there, from 54% to 78%. So that's quite interesting. And if you believe all the, I'm not an expert on statistics and numbers, but if you believe that, you know, there's a big cost saving there already, just demonstrated in that case. And I think that's my 10 minutes. I don't think there's another. Oh yes, there is one last slide. I beg your pardon. So we just, you know, there's lots of discussion points out there about this, but you need to know who's in your team and the level of knowledge and skill the team's got. The pharmacy technicians, I think, are essential. And the bit I forgot to say earlier, sorry, is, if you're blending these work with all the QOF recall anyway, quite often you're just using the practice technicians to do all the bloods and the measurements and the weights and the blood pressures and everything else anyway. So if you just join it together with the existing QOF work with existing members of the team, that's really important. And that's really the point there. You need to have somebody who can just help you with the data in the practice. And the booking system is really important. And as Claire and others have said, giving the patients the information around this so you really get better patient engagement and better quality of these things is really important as well. I hope that's okay for 10 minutes just of our experience.
No, that was brilliant. Thanks so much, Lawrence. That's really, really helpful to hear sort of from your perspective, how it's kind of worked. So that's great. Adam, did you want to share your own slides, or I'm happy to be button clicker for you?
Yeah, hi, Claire. Yeah, I'll try to share. I'll try to share my slides.
Yeah, no problem. It's much easier.
Second. So hopefully everybody can see that.
Yeah, brilliant. Thank you.
Okay, great. So first of all, thank you very much for inviting me to come and talk to you a little bit about polypharmacy and health inequalities. My name is Adam Todd. I'm a pharmacist and an academic based in Newcastle School of Pharmacy. So I suppose really I thought I'd just try to set the scene a little bit in terms of health inequalities and some of the challenges we see in the real world. And so tomorrow I have the joy of travelling down to London from Newcastle, and going to the Newcastle train station. I will get our Tyne and Wear metro, and that's, I suppose, it's like our local train transport infrastructure. To be honest, I'd probably give you 20 minutes on how bad a service the metro is, but I'm not going to do that. But if we just look at the healthy life expectancy along the metro train, we can see a lot of variation. So we can see the healthy life expectancy at the airport is 74.8 years, and less than 5 miles away, we see the healthy life expectancy at Fordham is 66.1 years. So a difference of around 9 years we're seeing in healthy life expectancy within a 5 mile radius, which is really, really quite shocking and probably surprising for a lot of people. And actually, if we go further down the metro track, we could compare the healthy life expectancy between the airport and Byker, which again, so it's on the same, if you like, metro system. And there we see a difference in healthy life expectancy for around about 11 years. So that really shows, I suppose, the challenges of health inequalities in the region of Newcastle. But actually, when I get on the train and head down to London, we will also see on the way examples of health inequalities between regions. And this essentially shows you a map of England with the various East Coast and West Coast Main Line. And again, you can see the cities with various colours next to them. And if you see a red dot, you can see that on average, the life expectancy, this is life expectancy for men, on average, the life expectancy is lower than the national average. If we see green, it's higher than the national average, and if we see amber, it's about the average. But there you can see a huge variation within the country, and certainly on the West Coast Main Line, you can see kind of a lot of red in the north and then a lot of green in the south, and we probably call that the north-south health divide. And again, if I was to go further, if I was perhaps going abroad or going on a plane, I'm not, unfortunately, but we would also see health inequalities between countries as well. So there's a lot of variation in terms of healthy life expectancy and also life expectancy. I appreciate colleagues will have heard this definition before, but this is really just a definition of what health inequalities are about. And really, health inequalities are about the unfair and avoidable differences in health across the population and between different groups within society. And again, these differences might include health conditions, health outcomes, the experience of care, or what care is available to different people and different populations. And just having a look on your website, so the NHS Hampshire and the Isle of Wight website, health inequalities is mentioned, which was great to see. So I suppose there's a plan there around trying to tackle and reduce health inequalities, and there was a number of kind of overarching aims and projects outlined on the website, and in particular improving outcomes in population health, but also outcomes in healthcare, but also about tackling inequalities in access. And I think that's really important. And certainly a lot of the work I've done has really been around access to healthcare and the role of pharmacy and general practice and how that kind of all fits together. But again, looking further on the website, you can see that Hampshire and the Isle of Wight has particular challenges, I suppose, unique to this particular place. And one of the challenges that was highlighted was around the biggest gap in potential life expectancy between those that perhaps live in poorer areas and more wealthy areas was caused by deaths from cancer, circulatory disease, and respiratory disease. And again, that links into some of the work that I've done around cancer and cancer medicines. So I'll just take you through some examples because I think that might be relevant. But before we go to the specific examples, I thought it was just to highlight some I suppose key thinking in this area and really hopefully get colleagues to maybe reflect on this in their own practice and how maybe they could maybe change their practice as a result of these thoughts. So there's something maybe colleagues have heard about the inverse care law before, where that is about the availability of good medical care varies inversely with the need for the population served. So in other words, the inverse care law tells us that essentially where there is good medical care, generally the population will be quite healthy, and perhaps where the medical care or the healthcare is less good, maybe the population will be less healthy. So that's quite I suppose, a well-defined idea and concept that was first put forward by a GP in the 1970s. But there's also something called the inverse equity hypothesis that was first published in the Lancet in the early 2000s. And essentially what that talks about is essentially as we discover new technologies or new potential public health interventions, how those interventions reach society will not be equal. It will be different. And the thinking is that people who of higher socioeconomic status, so potentially people who have more education, perhaps live in more affluent areas of the country, will preferentially take up those new interventions and that new technology. And then over time, that technology will reach other parts of society as well. So potentially introducing a new intervention has the potential to exacerbate health inequalities. And just to give you an idea, so there's an Audi TT. And certainly when I was training to be a pharmacist many years ago, like an Audi TT was the car to have. Everybody wanted an Audi TT, and potentially maybe the most wealthiest people in society would have had an Audi TT. Whereas now, and apologies if anybody drives an Audi TT, by the way, whereas now maybe everybody's got an Audi TT and maybe the car to have is something like a Tesla or something like that. So that's just an example. So I was really interested in finding out, does this inverse equity hypothesis hold up for the NHS and potentially medicines we supply in the NHS? And I suppose a good starting point relevant to the cancer example is so immunotherapies. So immunotherapies are new medicines, really relatively recently discovered, very expensive, very effective. And essentially, it's a way to try to stimulate a patient's immune system to start recognizing and attacking cancer. And it's associated with very good outcomes for patients. But this is also an example of a new technology. And again, if we were to think about the inverse equity hypothesis, what we would see is we would see a preferential uptake by people of high socioeconomic status. And we were interested in finding out if that was true for immunotherapy supplied through the NHS. So we did a study on that. And again, I'm very happy to receive emails from colleagues or people want more information or want to read the paper. I'm very happy to send that. And this was a PhD student's work. So this is Ruth Norris, this is her work, and Ruth is a pharmacist in our university at the moment who's doing some really important research. And our hypothesis was that really that if, depending on where you live in terms of a least deprived or a most deprived area, that shouldn't really make a difference in terms of you accessing the expensive effective cancer medicine should you have cancer. So really our hypothesis was what this graph looks like. So as we can see, we've got the least deprived places according to the index of multiple deprivation to the most deprived. And really this is the odds of a patient receiving treatment living in those areas. So this is what we had expected to see. So in other words, the odds of treatment remains the same, depending on where a patient lives. So that's what we thought was going to happen, and this is what we actually found. So this is people living in England receiving these medicines on the NHS. So what we found is, as a patient lives in a more deprived place, the odds of receiving treatment significantly reduces. So in other words, just to interpret that graph, that people living in more deprived areas were 46% less likely to utilize any novel cancer therapy compared to those living in the least deprived areas. So in other words, medicines, as they are newly discovered and introduced into our health system, could potentially exacerbate health inequalities. And again, if you look at the outcomes from, say, lung cancer, where immunotherapies are typically used, we will see again a really strong deprivation gap. So as we can see from the graph for males and females, this is the age standardized mortality rate from lung cancer. And as you can see, if you are living in a more deprived area compared to a least deprived area, the mortality rate is at least twice as high. Even if we control the things that account for potentially people living in more deprived places are potentially more likely to get lung cancer, even if we control for those sorts of things, we're still seeing this effect. So again, I think one of our hypotheses is that actually, could this unequal access to treatment be driving the unequal outcomes we see? But just, I suppose, to summarize, if you have lung cancer and you live in a deprived place in England, you are a lot more likely to die from it compared to if you live in a more affluent place. So that was, I suppose, an example of lung cancer and medicines, and really a new therapy coming into the NHS. But what about polypharmacy? Because polypharmacy's been there, the concept's been there a long time. It's not really a new technology. Do we see inequalities in polypharmacy in England? And this was the work of a very talented PhD student who's a pharmacist at Newcastle, Anam Iqbal. And Anam started off her work by doing a big review of the literature to see, do we see differences by socioeconomic status in polypharmacy? So she did this big review. It took a long time. And what she concluded was, yes, there is a difference where we see people of lower socioeconomic status are more likely to experience polypharmacy. But when she did this review, there was a number of gaps that she found. And one of the gaps was really that a lot of the studies we included were not from England. They were largely from the US with a different health system. And again, a lot of these studies didn't really look at changes in inequalities over time. They just give really a snapshot of one point in time. And finally, a lot of the studies didn't really think about multimorbidity in patients as well, and potentially could that increase in multimorbidity, potentially people living in more deprived places, could that be the driver for increased levels of polypharmacy? So with those kinds of questions, we then set off to try to answer them. And how we did that is we used different cohort studies. So again, I'm sure people are aware that a cohort study is essentially a study that recruits a series of people and follows them over time. And one cohort study that's fairly well established in the country is CFAS, so stands for Cognitive Function and Aging Study. And CFAS was really established to research dementia and actually dementia prevalence, and think about the different lifestyle risk factors that might contribute to dementia. But as part of CFAS, they also collected information about medicines and prescribed medicines. So we were able to access that data, and there are different, I suppose, examples of different CFAS studies. And the first one was done in 1992, which seems like a long time ago now, and just let people kind of go back in time. So 1992, Whitney Houston was at number 1. My beloved Alan Shearer was scoring goals for Blackburn Rovers, and Prince Andrew and the Duchess of York, Sarah Ferguson, separated. But we also had, as I say, the CFAS-1 study where they recruited over 7,000 people from 3 study sites in England. And then we were able to access data using the same study, but on a different cohort of people nearly 20 years later. So this included information from 2013. And again, just to take you back in time then, again, it was very different to it is now. Bruno Mars was at number 1. Prince George was born, and we had a rather an interesting government as well, which I'll probably not talk about. And what we found is actually looking at medication over time, we can see that amongst older people, the patterns of medication use really changed. And from CFAS-1, from 1992, we can see that the median numbers of medications people were taking. This is older people over 65 years old. The median number was 2, so 2 medications. The highest numbers of medications people were taking was 8 medications. And then if we fast forward to 2013, and the prescribing did change quite a lot. So we've seen a lot more people taking a lot more medicines, and the median number of medicines the participants were taking was 4. But interestingly, we've gone up from actually the maximum number of medications of 8 to CFAS to the maximum number of medications we seen was 23. So in other words, over time, the numbers of medications we are prescribing are going up, and more people are experiencing polypharmacy, or the use of multiple medications. So that was a really interesting thing to study and find out. And again, if you look at the actual prescribing of the medicines, again, you'll see a lot of differences there. Now, moving on to, okay, so maybe polypharmacy changes over time. What does that mean for the inequalities in polypharmacy? And again, apologies about these graphs, but just to kind of explain them. So what we have here on the bottom axis is levels of education. So on the left, we have people who are educated less than 10 years. So if you like, lower levels of education, to people who were educated more than 12 years. So high levels of education. And our comparator is people who were educated between 10 and 11 years. So if we just ignore the red dots first, and what we can see is the odds of somebody with low education levels to be in receipt of polypharmacy compared to medium education was about 1. And if we look at that compared to the higher education, we can see the odds of the person in or the people in higher education are lower than 1. Okay. Now, if we adjust in our analysis, so if we try to adjust for differences in age and sex and levels of multimorbidity, these are what these red dots signify. And as you can see, actually, the adjustment doesn't make that much difference to our conclusions. We've still got odds for the low education people of about 1, the high education people of less than 1. So that was CFAS 1, remember, back in 1992. So to interpret that, we can see that people living with high educational backgrounds were 19% less likely to be in receipt of polypharmacy. So in other words, the highly educated people back in 1992 were less likely to experience polypharmacy. Apologies. Just go back. And if we fast forward to CFAS 2, so 20 years plus in the future, we can see that actually it does look a little bit different. So here again, we've got the education of participants on the bottom. So on the left, we've got lower education levels. And on the right, we've got high education levels. And our comparator is the medium education levels. And again, what we can see that for the lower education levels, if we just look at these black dots, we can see that the odds of polypharmacy is a lot higher than 1. Again, people with higher education levels, the odds is less than 1. Now, in this case, when we adjust for age, sex, and multimorbidity in the analysis, we do see a difference there, but ultimately that red dot is still above 1, and for the high educated people, the red dot is still below 1. So again, to interpret that, what we can see is that people living with high educational backgrounds in 2013 were 21% less likely to be in receipt of polypharmacy compared to those of medium education backgrounds. But actually, people living with low education backgrounds were 13% more likely to be in receipt of polypharmacy. So I suppose to sort of conclude from that, what we're seeing is that actually over time, polypharmacy is, if you like, increasing. People are taking a lot more medicines than they were previously, but actually the inequalities in polypharmacy, and so the socioeconomic inequalities between people who are highly educated and not well educated, are increasing as well. So that gap, what we're seeing, those inequalities are increasing over time. And I think that's really interesting. And I think, we tend to talk about the numbers of polypharmacy, the prevalence of polypharmacy, and that is super important. But actually thinking about this problem through a health inequalities lens is also equally as important as well. And again, I'm sure that people will probably understand this more than me, but we know that polypharmacy is associated with adverse outcomes. So sometimes polypharmacy can be appropriate and absolutely do good things, but sometimes it can not be appropriate and it is associated with negative things. And again, the literature on this is a little bit complicated. It's not straightforward, but as you can see, that the things highlighted in green are, if you like, the associations are stronger, the evidence is stronger. Those highlighted in amber, there's an association there, but the evidence is less clear. And the last thing I really wanted to mention is the concept of intervention generated inequalities. So I suppose we know that some interventions that we offer, whether or not that be in public health or healthcare, are designed to obviously increase health, which is obviously the purpose of them. But what research tells us is that actually some interventions can improve health overall, but actually exacerbate health inequalities. So in other words, they can widen the gap between people of low socioeconomic status and high socioeconomic status. And again, I've heard lots of interesting talks and discussion around SMRs, and I would just really encourage colleagues to think about SMRs, how we offer them, and whether or not we are potentially exacerbating health inequalities by doing so. And just to give you a fairly well-established example, taking folic acid while pregnant is again has a lot of health benefits. Now, what we know is that if we try to promote folic acid uptake through education or having awareness campaigns about the importance of folic acid, we know that approach, although improving health overall, will exacerbate health inequalities, because people who are more educated, who better understand the system, are more likely to read, understand the advice, and increase their folic acid intake. What would be a better approach is, rather than having an educational intervention or an awareness campaign, would just be to provide folic acid for free, available to everybody, or targeted at specific people. And we know that intervention, that approach, does improve health overall, but it also helps to close the gap in terms of health inequalities. So again, as I was saying, I think I would really encourage colleagues to reflect on SMRs, and I'm sure they're absolutely very good and they improve health and reduce inappropriate prescribing and all of those sorts of things. But potentially, how are we offering them, and is there a potential that we are thinking about an intervention generated inequality? So just to summarise, health inequalities are a huge challenge to our society. We see health inequalities all over the place, within regions, between regions, within countries, between countries. And I think we do see examples of health inequalities with medicines, even in our NHS, that is supposed to be, I suppose, free at the point of entry. Health inequalities in polypharmacy are getting broader, despite a modest increase in multimorbidity. And I think I would encourage colleagues to really think about the challenges of polypharmacy as a whole, but also through the idea of a health inequalities lens as well. So thank you very much. I will stop sharing now.
Thank you, Adam. Thank you. I think that's really helpful and a really, a really good challenge. That actually we've talked a lot about targeting patients, but actually ensuring that we're doing that in a way that doesn't worsen any sort of health inequalities that we have already in our system. So can you see Dan? Yeah. Right. So to round off the talk today, unfortunately, you've got me. So I just wanted to quickly touch on, getting started with SMRs, and if this is, for yourselves, if you're one of those people who said that you weren't so confident about getting started with them, or in terms of supporting other team members with getting started with them. I've put this document in. It is a little out of date, some of it later on, the links in it, but actually I think this slide, this beginning bit is still quite helpful around, that process really of gaining competence for SMRs, whether that's for yourself or for your staff, and how you might think about that. So I think, that top box is about thinking about your practice population. Obviously, we would definitely include in that, the deprivation levels that you've got around your population as well, and sort of how you might use that to think of some objectives. We're going to share these slides out, so you'll have all these links. But then I just wanted to really quickly maybe touch on some example areas that you might want to think about in terms of getting started or picking patients out for if you're not already up and running with this kind of work. So the first bit I've put there is about trials without. So, there's so many medicines where we just don't know if they're doing anything anymore. The patients don't know if they're doing anything anymore. And so really the only way to find out is to trial a stop or trial a dose reduction and just see what happens and follow the patient up. And I do generally find patients are really receptive to that if you are honest and you say, we just want to find out if there's a good reason for you to keep taking this. I probably have a conversation about once a week about amitriptyline for this reason. And honestly, 7 times out of 10, nothing happens when they stop it and we end up stopping the medication entirely. So I think it's just a really good starter for 10 in terms of building confidence with deprescribing, that actually there are quite a few medicines where we can just try without and see what happens and see how things go from there. I've put in next about statin treatments. Obviously, the caveat here is it depends on what group of patients you're reviewing. So if they are a younger population, please do think about starting them or optimizing treatment. But obviously, predominantly today, we're talking about overprescribing and older adults and safety. So, thinking about, is this patient really going to confer any benefit from this treatment? I think the evidence has been patchy at best and a little bit conflicting over the years, but I think we can all sort of agree now that if their life expectancy is under 2 years, they are very unlikely to get any benefit from a statin treatment. We have really limited trial evidence. We have one clinical trial that looked at older adults and they only went up to 82 years old, I think. So that's not really who we're seeing in practice. And they actually found there was no evidence for primary prevention in older adults. So it's really about having those conversations about whether this is going to be beneficial. And I've put a link on there for some lifestyle calculators. So these are still kind of in their infancy, but actually I think they can sometimes help to kind of guide those conversations. So rather than looking at traditional kind of 10-year cardiovascular risk, looking at that lifetime risk and that treatment effect for patients. So, for example, I was looking at this morning with a lady who's 79 who has cerebrovascular disease and AF, and actually it said that her risk was 50% whether or not she took a statin because of all the other patient factors. So it can kind of help guide those conversations sometimes with patients. I've also put on there about hypertension. Again, the caveat, if someone is younger, please do optimize treatment. But in terms of our older adults or those with frailty in particular, are they going to really get benefit from this treatment? And the NIHR did a huge review looking at 4 million people with hypertension, and they found that once people were over 80, blood pressure medication was as likely to cause a serious fall as it was to prevent a stroke or a heart attack. So these patients really are sitting in the balance and we just don't know which way it's going to go. So I think it's really important we're having conversations with people about that, about the lack of evidence, and thinking about having a really low threshold to stopping medication or reducing doses. If there's any adverse reactions, if they're having postural hypertension, if they're having muscle aches and pains, we want to prevent those falls. We want to extend quality of life. So actually, kind of tackling that proactively and head on. I've put in there about antipsychotics. I appreciate maybe not everybody on the call today, deals with antipsychotic prescribing, but I think, we've got so much evidence out there now about how dangerous these medicines are. It's really just worth kind of reiterating it. So we've had, the evidence that's come out this year from the repeated study in the BMJ, some of the numbers needed to harm are terrifying. So for pneumonia, the number needed to harm was 9. I think for stroke, it was 29. AKI was 30 something. So these are really risky drugs for our patients to be on. And we need to ensure that when we're doing that 6-week assessment, it's a trial stop or a trial dose reduction. It's not they're getting on okay, so we'll continue the prescription. And we are working with our OPMH colleagues to really try and tackle this. I've also put in about PPIs because we know that people get left on proton pump inhibitors long-term quite often, and the long-term use has been associated with lots of things, but predominantly sort of hypomagnesemia and increased risk of fracture. But we're also getting a bit more evidence out now about the increased risks of gastric cancer, particularly in patients who originally were given treatment for H. pylori eradication. So when that treatment is then continued long-term, their risk of gastric cancer increases quite significantly. So, and when you look on open prescribing, which some of you may do, it's free to access. We can see as an ICB, we are quite high at our high doses of PPI prescribing, and it's not really coming down. So I think this is probably an area, we all in practice might want to have a look at and just see if there's anything we can do there, because the risks of gastric cancer were time and dose dependent. So if we can get people even onto lower doses, that would be beneficial long term for their health. Then the last one I put on there is just about diabetes management, because again, I think people probably are normally quite involved with this. So again, it's that, what is the target HbA1c for that patient sitting in front of you? Not based on their age, but based on their functional status and their frailty. Again, the evidence is is getting there. We've probably got more for diabetes, and we've had some expert consensus reviews which have been really helpful. So talking about how frailty rather than age should really practical. So it's got a column on there about the target HbA1c you're looking for depending on a person's frailty, but actually also that de-escalation threshold. So what HbA1c you would start thinking about deprescribing. So again, it's that proactive approach, not waiting for that person to have hypos and start falling over, but what can we do before that time to try and prevent that from happening? I know we've talked about frailty a lot, so I think everyone is familiar now. It's that loss of physiological reserves, you know, it's that significant functional decline from a minor trigger. And I think traditionally we always talk about that minor trigger as being an infection, sometimes a fall, but it's just worth remembering that it can also be a side effect of a medication or an adverse drug reaction. So just to kind of have that in mind when we're thinking about prescribing. We know that increasing frailty leads to an increasing risk of adverse drug reactions. It's not an inevitable part of aging, which is why we don't like to put age labels on things. You know, sort of 50% of your over 85s won't have frailty, but it's just worth thinking about when we're seeing older adults in practice. And that bottom box there, that sort of picture, hopefully everyone can see, is from the new European Society of Cardiology guidelines, where they have sort of semi-mapped their kind of treatment guidance to CFS scores. So, you know, evidence is kind of getting there and guidance is sort of catching up to frailty. So there are more practical things out there now, which is really helpful. So again, that one just highlights about using ambulatory monitoring. So we're picking up any hypotensive episodes and trying to get down to sort of single therapies when they kind of get later on and have more severe frailty. So I'm not going to witter on too much today because we've had some wonderful talks from other people, but just some takeaway tips are really once we start to see hospitalizations and transitions of care, so patients not going straight home from hospital, but going via rehab, via reablement, that's normally, not always, but normally a pretty good sort of trigger point to think about, do we need to reassess how we're approaching medication, and actually do we now need to think a bit more about symptom control and lifestyle benefit rather than long-term sort of disease management. I think sometimes it can be really overwhelming. I mean, we've just seen some terrifying statistics, haven't we, all afternoon about how many medicines people are on. So actually, where do you start sometimes? But if you met that person now today with that as a new diagnosis, what medicines would you start? What medicines would you feel were safe for them in their current presentation? And perhaps kind of going from there can be helpful. The standard advice really for older adults, so start low, go up slowly, and that regular review and increased monitoring for people with frailty. So I am going to stop there and we are going to go to the Q&A, though I think Claire has admirably covered most of them as we've gone through, which has been brilliant. So I don't know if all the speakers could put their cameras and whatnot on. And we'll just go through. Jo, I don't know if you're on that.
I'm attempting to be. I start from the bottom, again, conscious that Claire has answered quite a lot of these already. One of the first questions we got in, can you still do an SMR if the patient has less than 10 medicines?
Yeah, so I mean, I've said absolutely. Claire, I don't know if you want to chip in a bit more on that one.
Yeah, so what we teach on the action learning sets is, and it's a bit like Lawrence described, don't just go at this. You need to sit as a practice and go, right, who've we got in terms of our team? How many sessions? Then go and look at your data and go, how many people on 10 or more medicines age 75? And it might work out really nicely, or you might say, oh, hang on a minute, we haven't got enough pharmacy sessions. So let's prioritise our over 85s on 10 or more first. But if you've got a big team of pharmacy technicians and pharmacists, you might have already been doing that for a few years. So you can start to go down to 8. And in Lawrence's practice, I know Steve is starting to look at the over 8 medicines, over 65s, because he's been doing this a while. That's why the data is so important. Like, marry the data up with what you've got in your practice team. And if all you can see in the next 6 months is 20 people, that's still great. Go and find those 20 people who might be on 20 or more medicines. So that's why the data should drive that. But absolutely, I can't remember who it was who put the question. It's like, yeah. And when you look at the indicators, the therapeutic comparators, you might find you've got patients with very high anticholinergic burden score who are only on 4 medicines, but actually they're at quite big significant risk. So they might be a priority as opposed to some people on 10, but perhaps not as great a risk. So it's about flexing it for what your team's capacity and capability are. I hope that's a sort of slightly longer answer than absolutely yes, but yes.
Yeah, absolutely. Yeah, definitely. Thank you. I think that's it, isn't it? And sometimes, with patients who have got, 20 odd medicines, sometimes there's actually very little you can do because they really are being held together by all sorts of comorbidities and everything. And actually, it's the people on 6 or 7 medicines, we can cut them down to 2 or 3. So yeah, it is about just sort of flexing, isn't it, with the patients that you've got.
Next question, is there a way to modify the templates, e.g. the wording, to the teams and the practice needs?
Is this about the HIN materials or the template in the practice?
A very good question.
Well, I'm not sure if you're there. I think in terms of the Ardens, we don't. If you're using Ardens templates, you can obviously feed that back to Ardens and see what they can tweak for you. You can make your own templates if you've got someone savvy enough in your practice, and obviously then you can have them say whatever you like. But Claire, I don't know if you want to talk about the materials just in case. We'll do both.
Yeah, you can. They're all downloadable, and in fact the idea was always you would stick your practice logo on them, particularly if you're sending them physically out to patients, which we know, again, back to health inequalities, some of our older patients aren't on an app and aren't on a smartphone, so we need to post the invitation to them. So there's nothing to stop you putting your logo on. You can change them. So yeah, they're all available as Word documents too. They're very evidence-based and they were designed by patients. So I might suggest you don't completely rewrite them sitting in a room on your own. Why would you do that when a group of patients who clearly understood this topic got the wording quite right? So I think it's just about balancing that up. But yeah, you can modify them for sure.
Next question, is there a code for SMR follow-up consultations?
Again, I think Claire and I think we had a conversation about this. Personally, I just code a follow-up consultation and then I code SMR again because then you can find it. I don't think there is a specific code for an SMR follow-up. Claire, you had a little look in the background.
I put that little box in that's got, because again, I've found quite a lot of practices have asked me about the actual read code. So you recognise straight away, okay, they've not been coding any of them. So they might have been doing them, but not coding them. But I don't think I've come across a follow-up one, but I will do a bit of scouting about, and if I do find something, get back to you.
Thank you.
Next question, shouldn't people with stents stay on with statins?
Yeah, and this is where we get a little bit unstuck, isn't it, with older adults? Because yes, the evidence suggests that, yeah, if you've got a stent, you should carry on with a statin, absolutely. And this is, where everything falls down, because there'll be nobody in those stent trials that was 85 or had any other comorbidities potentially. So it's really challenging because actually we don't have any evidence for them being on it, and we don't have any evidence for them not being on it. So it really is down to, that person in front of you, the function that they have, the frailty level that they have. And actually, as I said, some of those lifestyle calculators can sort of help with maybe judging that a little bit in terms of, is this person likely to get much benefit? And it may be that they would, because, they have a stent, they have significant cardiovascular history, and actually they're reasonably well. So for now, carry on while they're having no adverse reactions. But it's not straightforward, unfortunately, and we can only hope and pray we get more research from our wonderful colleagues here that helps with sort of making those decisions. But it is really challenging. Claire, I don't know again if you want to.
I think for me, when you get to that point where it's becoming highly complex, say imagine we've got someone who's 92 now and they are a frailty score of 7 or 8, and you're starting to look at 10 medicines or whatever. I think it's really important to have a conversation with the patient and say, look, you are on lots of medicines. Are there any here you don't want to take or you don't feel are being benefit? Some patients will say, I'm wedded to my statin because the cardiologist who I loved 25 years ago told me it was for the rest of my life, and leave that alone, particularly if they're not getting any side effects for it. But they might say to you, well, I don't know what this one's for, and I take this one every now and again. And by having a conversation, all of a sudden, all these weird and wonderful things come out from the patient. You go, oh, this is who I'm dealing with. with. Let's make the medicines work for that person. And it is, you know, it's great when you get to that point, and the science won't be there to tell you, but the person in front of you probably will give you the clues as to what to do. It's hard. That's why a lot of you have asked about how long for an SMR. It does depend on your experience and your skill, but if you're newish to this, you need to, and you've never met the patient before and you're doing it over the phone, like that makes me nervous, if I'm honest. I think particularly for these very complex ones, you need a relationship with the person to get into some of this. Okay, well, what matters most to you now? Particularly you might be in your, you know, later years where we've got to work out what's important to you and what you want to get out of your medicines for the next few years. So yeah, it's tricky, but that relationship is key.
Yeah, thank you. Absolutely.
And then that's, I think, everything from the Q&A, but there were still some questions in the chat. So I've gone back to the beginning of those, which again, I know, Claire, you've already answered some of them, but I'll just mention them again. Is there any evidence for the effectiveness of SMRs in the Rs era, and have we managed to maintain the quality of SMRs with a broader pharmacy workforce?
Yeah, so some of the newer studies are the current, you know, if you think we've had the Rs now 5-6 years, I sort of forget, is it even a bit longer? So it is hugely variable, and I think obviously any study will be looking specifically at people who you imagine it's not their first day of work and they've perhaps been in primary care a little while. Those practices are more likely to volunteer for research, but they are variable. But I think if you as a practice have got a good setup where you're using data, you're finding the right people, you've got your team set up as Laura described, you're very likely to replicate. Remember, in Ireland, the pharmacists aren't even prescribers. They've got to go and write to the GP and go, can you stop this medicine? And then the GP's either got to take that on board or not, and they still showed a massive benefit. I would argue we're much further along the line than that. But I think as a profession, and we've a few GPs on the call, but as a profession of pharmacists, we have to recognise, you know, some people have gone in and not really been able to do this primary care job brilliantly well. And we've got to think about that. How do we support the teams in primary care to make sure the work that we do is of the highest quality, particularly when we get an opportunity with a patient to do that review. So yeah, it is a big challenge. I think we're right in the middle of that challenge right now.
Were there any other questions, actually, just quickly, so I'm conscious we're coming towards the end. Is there anything else anyone want to type or ask?
Well, there's a question about any practical tips to overcome time constraints. I guess part of it is around, like you said, targeting the right people and with your time, and I guess using that wider MDT team.
Pharmacy technicians.
Was there anything about that from any of your, either the studies, Kinder, Eloise, was there anything around sort of time constraints or?
Yeah, I mean, and Wiz would probably be better to answer this question based on Modify, but it's exactly relying on the other people in the team based on their expertise. So like the preparation could be done in collaboration with the pharmacy technician. I think when we talk about preparation, people are scared that this is adding more time, but it is not really, because you are more prepared. So you might have a shorter medication review because you have a better picture of the patients. But yeah, it's just organizing your time and making sure that you are targeting high risk patients. Take it, as Lawrence mentioned, they did only 2 sessions a week targeting polypharmacy and high risk patients. So it's just trying to manage the workload and doing it in chunks, probably the best advice.
Okay, shall we, so I'm just getting the right slides up, background, lovely. So I think I can't see more questions, so we'll draw to a close there. I should say thank you so much to all our speakers today. It's been fantastic to have you here. Thank you so much for putting up with all my terrible organisational skills and turning up today. So thank you. I just wanted to highlight that we do have a page on our ICB website that does detail any kind of further upcoming learning, and we do have the calendar on there that shows what's coming up, and also sort of recordings for previous events, which is where this will all be uploaded to. And I think,
just to add, we'll be sending out feedback forms, like I said at the beginning. One of the questions will be around any additional learning that you guys want. So please contact your MedSop team or get in contact with us just in terms of what we you would really find helpful, and whether or not you want to us to help you to direct you to some of the hidden resources and anything like that. Anything that you need from us, please do let us know. Thank you.
Absolutely. Thanks so much for joining us today, everyone. Thank you.